Welcome everyone to this lunch lecture today, which we have entitled Bench, Bedside or Both. I'm Magnus Bäck. I'm a professor of cardiology here at the Karolinska Institute and at the Karolinska University Hospital, where I work within the division of valvular and coronary heart disease. And I also like to say welcome to our YouTube watchers and tell you that you have tuned in to a seminar series which is being recorded at the Karolinska University Hospital, Huddinge-Flemingsberg campus. And I'm here today with a group of students and fellows who have come here to get inspired. So it's a very challenging task to inspire, but I hope today that I'm able to get you inspired, or at least that I can share with you my enthusiasm over translational research, and in particular, translational cardiology. So let's start by doing some definitions here. So what do we mean by translational cardiology? Well, first of all, what is cardiology? Well, this is rather simple and rather straightforward. It is taking care of the heart, right? But the heart can have several different problems, and cardiology is a very vast specialty which addresses several different parts of cardiac problems. And as I told you, I work with coronary and valvular problems, and those are the things that I will discuss with you today here. So, what is translational cardiology then? Well, first of all, translational cardiology is the name of my research group. So here you see a great group of people with whom I'm working every day to try to resolve the problems of research within translational cardiology. You can visit our homepage to learn more about what we do, and you can also follow us on Twitter to get updates on important activities, such as the lecture you are just attending right now. But if we go to a dictionary then and check what is translational cardiology, well, this is the response we get. It doesn't exist. Okay, so we'll have to try with something else. So what about translational research? Yes, here we do get a hit. And I think this is a kind of nice definition of translational research. It is medical research which is concerned with facilitating the practical application of scientific discoveries with the aim to prevent, diagnose, and treat disease. And this is, of course, very important. It also says in this definition that the first known use was in 1986. But indeed, this is not as new as this as a principle, because research to make a better prevention, diagnosis, and treatment of disease is not something new. Okay, on a more existentialism side of the life of a scientific or a physician scientist, the eternal question, am I a scientist? Am I a doctor? And can I do both? And this is what I like to share my enthusiasm today, that it is possible to do both. So let's start looking into a little bit the problem of coronary heart disease and atherosclerosis. And just to give you a background, I'm just going to very briefly go through the basics of atherosclerosis, and with the important notion that this is a chronic inflammation. So it starts with the uptake of lipids within the vascular wall, of low-density lipoproteins, the oxidation, the modification and oxidation of these lipoproteins, and the inflammatory reaction, the recruitment and activation of inflammatory cells within the vascular wall that builds up this mix of inflammatory cells and lipids within the arterial wall. And this is chronic because it goes on for several years. But it does also have an acute phase, because this atherosclerotic plaque, that we call it, can become vulnerable, an increased inflammatory activity, and different things that go on that makes this plaque unstable. And one of the things that we'll talk about today is the presence of bleedings within the vascular wall, which is referred to as intraplaque hemorrhages. And this is one of the key signs of the unstable atherosclerotic plaque. And this can lead to plaque rupture, which then will lead to thrombosis and a complete occlusion of the vessel. And if this happens in a coronary artery, we'll have a myocardial infarction. And if it happens in the cerebrovasculature, we'll have a stroke. So this is very basic and fast, the background of atherosclerosis. But remember this, it is a chronic inflammation. So can we target this inflammation in some way? Well, first of all, we have to look through what does a normal inflammatory reaction look like? Well, we will have an acute inflammation in response to, for example, injury or infection. And then we will have the appearance of the stop signals. And those stop signals will lead to the stop of the inflammatory reaction and also to the resolution. And this is an important point also, that the resolution, the disappearance of inflammation is not something passive. It is an active process, and it brings back an inflamed tissue to homeostasis. So, if we don't have a correct resolution of inflammation, we will not have these stop signals, and there will be a green light for the inflammatory response. There will be no return to tissue homeostasis, and instead the result will be a chronic inflammation. And this is what we refer to as a failure in the resolution of inflammation. So if you're famous, you get your face on a stamp. And I chose 2 stamps today to illustrate the resolution of inflammation. Probably you know who this guy is. This is Zlatan Ibrahimovic, as an example of an effective resolution, the way he recovered from his knee injury that he got when he was playing in Manchester United. On the other side is a person that is also very important for the resolution of inflammation. This is Bengt Samuelsson, who was one of the 3 Nobel laureates in 1982 for the discovery of lipid mediators, prostaglandins and other lipid mediators. And lipid mediators are very central in the inflammatory response. So one of the lipid mediators, one group, is referred to as the leukotrienes. And leukotrienes are formed from arachidonic acid. And those leukotrienes are part of the green light signals for inflammation. So they lead to this leukocyte recruitment, to the leukocyte activation, and to several of the characteristics of the inflammatory reaction. But we also have other lipid mediators, for example, lipoxins, that are these kind of stop signals that mediate the termination of the inflammatory reaction, the termination of recruitment, the active efflux of inflammatory cells from inflammation, and the clearance of apoptotic cells from, for example, an atherosclerotic lesion. And in the normal inflammatory reaction, we would have this switch, the lipid mediator class switch, which goes from the pro-inflammatory to the pro-resolving signaling and the resolution of inflammation. So ideally, we would like to stimulate these stop signals in some way. And it's important then to know that lipid mediators not only come from omega-6 fatty acids, but they also come from omega-3 fatty acids. And this shows the example of different omega-3 fatty acids that can be metabolized into a group of mediators called resolvins. And these mediators act as stop signals to induce this resolution of inflammation. And I see this really as a balance between inflammation and its resolution, and that this goes on all the time. And as soon as this balance is tipped towards inflammatory response, there is a problem. And what we would like to do is to tip this balance towards the resolution of inflammation to terminate the chronic inflammatory response. And indeed, it is known that omega-3 fatty acids have beneficial effects. It's been known for a very, very long time. This is from a publication in 1979 so even before the term translational research was used. Where it was shown that in Greenland Inuits, the cardiovascular risk was very low, and this was associated with a high marine food intake, so a high fish intake. So as a translational scientist then, we want to know why. Why can omega-3 fatty acids be beneficial for the cardiovascular system? Well, these are some of the mechanisms that can be involved. Omega-3 fatty acids lower triglycerides, and they also affect the balance between thromboxane and prostacyclin, and they'll be antithrombotic. And this is what we're going to talk more about today. They may also alter this balance between the stop signals and the green signal for inflammation by decreasing leukotriene formation and increasing resolvin formation. So this is what they look like. We have the different fatty acids and the lipid mediators of resolution of inflammation. And this is another important point. They mediate this effect by activating specific receptors. These are two examples of the receptors, the ALX-FPR2 receptor for lipoxin A4 and resolvin D1, and the ERV1 CAMR23 receptors for resolvin E1. And what we have done is to create models to see that if we take away these receptors that then mediate these stop signals, what will happen to the inflammatory reaction. So we generated a model without these stop signals and then looked what happens in atherosclerosis and in inflammation. And indeed, in this model where this receptor was lacking, there was an increased inflammation and increased atherosclerosis. So it does suggest that this receptor protects against atherosclerosis. But how? Well, there are different mechanisms. One of the mechanisms is a defense mechanism against the uptake of these modified lipoproteins, the oxidized LDL. So we see an increased uptake if we knock out the receptor, suggesting that this pathway is protecting by reducing the oxidized LDL uptake. And finally, this pathway mediates phagocytosis, so the clearance of debris and of apoptotic cells within a site of inflammation. So an active clearance process when we have the resolution process of inflammation. So to summarize these findings, it is known that high fish intake reduces cardiovascular risk, but there have been trials with omega-3 fatty acid supplementation, and they have not been all consistent in showing protective effects in cardiovascular prevention. We know that omega-3 derived mediators, resolvins, transduce the resolution of inflammation, and that they do that through specific receptors. And I also evoked with you today this balance between the pro-inflammation and the pro-resolution. So how can we use this knowledge to translate and to use this knowledge for the benefit of our cardiology patients? Well, I'm going to show you an example just on how we did to take this a little bit further, and it was to look on leukotrienes and resolvins as biomarkers, with this really the balance between the two classes of mediators in mind. And this is a group of subjects that we have screened for preclinical atherosclerosis. We made an ultrasound examination of their carotid artery and just looked on the thickness. So the thicker your carotid artery, the higher your cardiovascular risk, and a sign of developing atherosclerosis. And then what we did was to look on the relative content. In this study, we used saliva to measure. And we measured a ratio between resolvin, the stop signal, and leukotriene, the green light signal. And we just made a cutoff at 1, saying if you are above 1, meaning you have more resolvins than leukotrienes, and if you're below 1, your leukotrienes, pro-inflammatory mediators, prevail. And this is what we could show. In this group, where leukotrienes prevail, this group of subjects had thicker coronary arteries compared with the other group, which had presumably a functioning resolution response. So we believe that this balance is very important. If you have inflammation, but you also have resolution of inflammation, you are in a different situation compared with having inflammation that is non-resolving. And the great challenge now, and the real challenge for all translational research, is to bring now all this finding into the actual benefit of our patients. And this is the goal of what we do. So we are working on now to see how can we promote the formation of resolvins from omega-3 fatty acids to stimulate this resolution response. And can we use this ratio between resolvins and leukotrienes, for example, to identify those patients that have a non-resolving inflammation and that have an increased risk because of this. So in the second half, I want to address my other passion within cardiology, which is valvular heart disease. And I'm going to talk today about aortic stenosis. So what is aortic stenosis? Well, it affects the aortic valve. And you see the heart here, and this is the aortic valve. So it's in between the left ventricle and the aorta, and it guarantees a unidirectional flow from the heart out into the vessels. Aortic valve stenosis means that we have a calcification, a thickening of the aortic valve, a reduced opening of the aortic valve. And this causes an obstruction of the blood flow, which may cause heart failure. This is the way I see aortic stenosis usually. These are images from echocardiography. And you can see a normal valve and this calcified valve. And I will show you in a couple of slides the reduced opening that this is causing and the obstruction. So this is what I see in my clinical practice. But since I always think translationally, I also want to look deeper into the valve. So we collected valves from cardiac surgery and we looked into the actual structure of the valve. And this is just an example of what it looks like. What is red or orange in this image is calcification. This is a healthy valve. It looks very nice, no calcification. Here it's a thickened part of the valve where it starts to thicken, and you can see these punctate calcifications that appear within the valve tissue. And then at the end stage of the disease, these enormous calcifications which completely destruct the architecture of the valve. But we need to look even further. We need to dig further from histology into cellular level and molecular level. And this shows a simplified overview of the pathological mechanisms that leads to this enormous calcification. And what I want to stress in this slide is inflammation, is a deposit of calcium, and at the very end stage, even bone formation in the valve. We call this heterotopic ossification. And if we look at these early stages of disease, where we have a recruitment, activation of inflammatory cells, this looks very much like atherosclerosis. And histologically, we also see the same image as in atherosclerosis in stenotic aortic valves. We see infiltration of lipids, of lipoprotein, oxidized LDL, of inflammatory cells. So is this the same disease? Well, some of the risk factors are also very similar. But in about half of patients with aortic valve stenosis, we see this. A heavily calcified valve, a reduced opening, this is echocardiography images, but a completely healthy coronary angiogram. So a very heavily calcified valve, but completely healthy coronary arteries, no atherosclerosis. And I'm obsessed a little bit with this presentation of disease. And these can be patients who are old, they can be 70, even 80 years old with this image. So two diseases which are so similar and that affect the valve, but not the coronaries, in about half of the individuals. So then is there a difference in risk factors? I mentioned a little bit the risk factors, and one of the differences that had been evoked before was that there was an obesity paradox, in that obesity was shown to be inversely associated with valve calcification, meaning higher BMI, lower calcification. This is a study which is old, 1994, and the subsequent studies had really been not very conclusive on the subject. So what we did, together with my colleagues, Susanna Larsson and her colleagues at Epidemiology, we looked into a large cohort that was followed for a long time, and then we stratified the patients according to their BMI. And we could show indeed that there is no obesity paradox in aortic stenosis, because those patients that had the highest BMI also had the highest risk of developing aortic stenosis. And we see the same thing for abdominal obesity, with the highest waist circumference being the highest risk factor. So these risk factors seem to be the same as for atherosclerosis, for example. But by going through several different risk factors, and I'm not going to show you all of the results today, we could show that there are some of the things that are similar between the classical cardiovascular risk factors and the risk factors for aortic stenosis. In addition to obesity, we could, for example, show that smoking is a risk factor for aortic stenosis. But there were also some differences observed in these studies, in that we could not see any protective effects of physical activity, for example, on aortic stenosis incidence. So to summarize the risk factor part, several of the classical cardiovascular risk factors increase also the risk for aortic stenosis, but we could also see some differences. And we believe that this way of comparing different cardiovascular outcomes in the same cohort can give us very important information why some patients develop both valve disease and coronary disease, whereas some develop one without the other. But of course we want to dig further. We are translational scientists, so we have to go further. So I've talked to you about the lipid mediators in atherosclerosis, and indeed there are also involvement of lipid mediators in aortic valve stenosis, both of different classes, I would say. And there is also another mechanism that I mentioned in the beginning of the presentation today of atherosclerosis, which is this vulnerable phase of the disease, the vulnerable atherosclerotic plaque, and the key role of the hemorrhages within the atherosclerotic plaque. And this is due to the fact that when we have a neoangiogenesis within the atherosclerotic plaque, which we also see in stenotic aortic valves. So when the valve gets thicker, it needs a blood supply, so there will be a neoangiogenesis. And also these vessels can bleed within aortic valves. So it has been reported before that there are bleedings within the valve. They're referred to as intra-leaflet hemorrhages for the valve leaflets. And is it so that this actually represents a vulnerable phase also of the valve disease? This could lead to the release of iron from the erythrocytes of different proteases, lipoproteins, and also be an entry point of inflammatory cells. And what we could show was that indeed we detect iron as a sign of bleedings within the aortic valves. And what is blue here is iron. And we can see that the more iron positivity we have in the valves, the more calcified they are. And we could also see that this iron positivity was associated with enzymes that are responsible for extracellular matrix modifications, such as, for example, MMP9. So, to summarize, I've talked today about the resolution of inflammation and how important this is to heal the chronic inflammation. I've talked about aortic stenosis and atherosclerosis, and that they are similar, but that there are also differences. And that these differences refer to both risk factors, but also similar and disease mechanisms in terms of, for example, inflammation and intraleaflet hemorrhages. And these are our challenges now as translational cardiologists, to bring this knowledge and what we know, to design new studies, to be able to further understand and to bring this knowledge to the benefit of our patient. So my last slide is also a key point for research in general. It is a teamwork. No one can work alone in science. And these are the names of some of the people that I've been working with and who have participated to the results I've shown today. My research group, and again, if you're interested, just follow us on Twitter and you will learn more about what we are doing, and had great collaborators in the different projects we are working with. So with this, I'd like to thank you for your attention and for being here today.